of Medical Sciences, and it's a great pleasure for me to be part of this pediatric cardiology classes. And today we are going to discuss a very interesting and useful clinical topic, the utility of myocardial perfusion imaging in congenital heart diseases. So myocardial perfusion imaging is conventionally done by a procedure called single photon emission computed tomography. It's a updated version of a conventional gamma camera imaging, otherwise previously called as a planar gamma camera imaging. Myocardial perfusion imaging is a well established investigation in adult cardiology, but somehow it is not routinely performed in pediatric cardiology, and I personally feel that should be because of the non-availability of nuclear cardiology labs in most of the pediatric cardiology groups. Also probably we do not know how we are useful to the pediatric cardiology practice, and the other way also is true that we are not being utilized to the maximum by pediatric cardiologists. But it is true that it is the investigation of choice for the evaluation of myocardial ischemia, and also it's the investigation of choice for the evaluation of the presence or absence of myocardial viability. Myocardial perfusion imaging is an investigation, and its greatest strength is its reproducibility. Also it has the physiological basis. Probably the only investigation as far as the evaluation of ischemia is concerned with a high physiological basis is the myocardial perfusion imaging. Also the strength of nuclear medicine is best exemplified by myocardial perfusion imaging because of the quantitations that can be performed along with the myocardial perfusion imaging in the form of a polar map generation, and also various indices which we are going to discuss in coming minutes. So we are going to divide our discussions into three. One is the various technical aspects of myocardial perfusion imaging. It is imperative to understand the basics of these technical aspects to understand and to interpret the myocardial perfusion imaging, and also what are the ways of stressing a child as far as the myocardial imaging to assess the provocable ischemia is concerned, and also the applications of nuclear medicine, that is myocardial perfusion imaging, in various congenital heart diseases. So let us first discuss about the technical aspects as far as the radionuclides and radiopharmaceuticals and the instrumentations are concerned. There is a basic difference between radioisotope and a radiopharmaceutical. The other name of a radioisotope is a radionuclide. There are two commonly used radionuclides as far as myocardial perfusion imaging are concerned, or one is 99M technetium and the other one is 201 thallium. We always like to have a radioisotope or a radionuclide with a gamma emission. Any radioisotope, it is an unstable form. When it comes to a stable form, it emits its extra energy in the form of a gamma ray or a beta ray or an alpha particle. But we always like to have gamma emission for imaging purpose because it can travel for a long distance, so that it can be captured outside the body of the patient using a gamma camera. Also we like to have a radioisotope emitting gamma rays, but with an ideal half-life. The ideal half-life somewhere hovers between 3 to 9 hours, and it also needs to be attached to a pharmaceutical so that it can be carried to the target organs. All these criteria are met by one radioisotope, that is 99M. 90M means stable. 99M technetium. It has a half-life of 6 hours and it emits only gamma rays which are ideal to the gamma camera, and it can be easily labeled to any pharmaceutical. On the other hand, thallium 201 is a radioisotope and it also has a gamma emission, but not an ideal gamma emission, but still it can be picked up by a gamma camera. So all the myocardial perfusion imaging still is popularly called as a thallium scan, because the initial and still one of the more commonly used radiopharmaceutical and radioisotope for myocardial perfusion imaging is thallium. But we are going to concentrate a lot on 99M technetium labeled radiopharmaceuticals and myocardial perfusion imaging performed with technetium, because technetium is the universal radioisotope available in almost all nuclear medicine centers, and it has made the myocardial perfusion imaging an affordable investigation to all the patients. So we have understood what is a radionuclide or a radioisotope. So it is also important to understand what is a radiopharmaceutical. A pharmaceutical is like any pharmaceutical which has a good targeting to a particular organ. Here the pharmaceuticals are selected as far as nuclear medicine radiopharmaceuticals are concerned will be selected in such a way that it gets concentrated in the desired organ but with no specific pharmacological action. The classical example and the most commonly used pharmaceutical in the myocardial perfusion imaging are two, sestamib and tetraphosphine. Both has a good target towards myocardium, and also this can be labeled with technetium. So a pharmaceutical labeled with a radionuclide or a radioisotope like technetium is to be called as radiopharmaceutical. Thallium itself is a radiopharmaceutical because it is available as thallium chloride and it has a high targeting towards myocardium. So it is a radiopharmaceutical. It need not be tagged or it need not be labeled to any pharmaceutical. So we have understood what is radionuclide and radiopharmaceutical. Now coming to the basics of an imaging equipment. Here the imaging equipment is a gamma camera, and when the patient emits a gamma ray or when there is a gamma ray being emitted from myocardium of the patient, it interacts with a sodium iodide crystal, which is the most important part of a gamma camera, and this interaction is conventionally called as scintillation. So only all the imaging procedures done in nuclear medicine are called as scintigraphy, and when there is a interaction of a gamma ray with sodium iodide crystal or when there is a scintillation taking place, what is produced is a photon or pockets of energy. So this photons or pockets of light energy is further converted into electrical signals, and these electrical signals are fed into the computer to get an image. So these images are conventionally called as scintigraphy. So we are also going to understand what exactly is a planar imaging and tomographic imaging. Planar imaging is the imaging of a three-dimensional organ in a two-dimensional way, like a chest X-ray, PA view or an AP view. And tomography is exactly like a computer tomography done with CT or an MRI, where you can have three-dimensional images or three-dimensional slices. Here, because we are using a photon, but also a single photon with reference to single scintillation or a single interaction of gamma ray, this is called as single photon emission computer tomography. This has to be differentiated and to be understood from PET or positron emission tomography, where the positron is going to produce two identical photons. So that is a positron emission tomography. Here what we are seeing is, or what we are using is a single photon emission computer tomography. Now the imaging equipments have also gone a lot of changes and advances, and what we have right now is a multi-crystal gamma camera. So how does a multi-crystal gamma camera looks? So this is how it looks. This is a multi-crystal gamma camera. So with this multi-crystal gamma camera, we can do myocardial perfusion imaging with most optimized way. So how it is optimized? This is the gamma camera in most of the nuclear medicine centers, and what we have is a dual head. So you can have two heads, and this head has that sodium iodide crystal inside, and after the sodium iodide crystal there are multiple electronic circuits which produces the electronic signal or electrical signal, and this is a variable angle gamma camera where these two detectors have now come to an angle between 72 degrees. So because it has come so close to each other, the myocardium is best image because there is no distance between the myocardium and the detector, thereby the best resolution is got from this imaging. So this is a dual head gamma camera and it rotates around the patient for 180 degree. It starts the rotation from position of PAO, that is the right anterior oblique of 45 degree to left posterior oblique, that is up to LPO 70 degrees. So it covers around 180 degrees so that the myocardium is best imaged in this particular tomographic picture. So this is the instrument that is used to have technetium produced every day. So this is something called column generator. You would have understood by this time that the technetium has a very short life of only 6 hours. So naturally every 6 hours it has to be produced. So it has a radioactive mother called molybdenum. This molybdenum is produced in a nuclear reactor and it is stuffed into a column in this lead lined generator or a instrument called generator, where this right side of this will have a highly specific molybdenum, radioactive molybdenum stuffed inside, and it has a life of around 72 hours. So every 72 hours it will become 50% of the concentration of molybdenum will become technetium, and this technetium can be extracted out or eluted out or milked out using normal saline. So this is another column, a vacuum column, and when you keep the saline through that, because of the vacuum it gets sucked in and it washes away all the daughter product here, that is 99M technetium. So this sterile form of technetium can be used to label the sesame B and tetrophosphine, and that's where we get 99M technetium labeled sesame B or tetrophosphine. So this technetium or this sesame B or tetrophosphine is supplied as a cold kit or non-radioactive kit, and when you add the technetium that is got from this column generator into that, you get a technetium labeled sesame B or tetrophosphine. On the other hand, thallium is produced cyclotron and it is supplied as thallus chloride, and it's in the sterile form which can be straight away injected to the patient. So what you get here also is a sterile form of technetium. So this can be intravenously injected, and this is aseptically labeled to tetrophosphine and sesame B so that you get the technetium concentrated into the Hello, Dr. Robin, are you able to hear now? Hello. Okay, I will. Dr. Robin, now you are able to hear, no? I should go to the next. Okay. And going back to the preparation of the technetium and radiopharmaceuticals. So now what's being shown here is an instrument called column generator, which is used every day to milk out the technetium which is used to label the radiopharmaceuticals like tetraphosphine and sestamine. Active mother called molybdenum. This molybdenum is a nuclear reactor produced radioisotope, and it is supplied in a highly specific activity in a highly specific way called column generator. This column is fully stuffed with molybdenum, and it has a half-life of around 72 hours. So it decays over a period of 72 hours to 50% of its daughter product called technetium, and this technetium can be extracted out, milked out and eluted out using normal saline, and this normal saline passes through another vacuum column here. So because of its negative pressure, it passes through this column containing a mixture of molybdenum and technetium now, and the technetium is milked out into this vial in a sterile form. So what you now have in our hand is 99 technetium, and this technetium can be labeled to a radiopharmaceutical like sestamine or tetraphosphine, and this complex called technetium labeled sestamine or tetraphosphine can be injected intravenously to image the myocardium. On the other hand, thallium is produced in a cyclotron, and this thallium in the form of thallus chloride is supplied in a sterile form, and this can be straight away injected to the patient because it is a radiopharmaceutical already available. So myocardial perfusion imaging is a unique investigation as far as the assessment of coronary artery disease is concerned because of its physiological basis, and it offers a high sensitivity and a good specificity in the assessment of ischemic heart disease. So this table clearly indicates the importance of performing perfusion imaging as far as the ischemic heart disease evaluation is concerned. It has an excellent sensitivity around 90% and a good specificity around 80%. When compared to any other investigation, non-invasive investigation, it has the best accuracy of around 90%. So let us discuss the physiological basis of myocardial perfusion imaging. So when there is a stress on the myocardium, there is an need or there is an increased oxygen demand, and this increased oxygen demand is met by a increased flow through the coronary vessels into the myocardium. But when there is a coronary stenosis, naturally there is a reduced perfusion to the myocardium through the stenosed coronary vessels. So there is less availability of perfusion tracers in the myocardium supplied by a stenosed vessel. So there is a stress induced ischemia, and when there is stress induced ischemia, there is heterogeneity in the blood flow. Your voice, are you able to hear now? In the availability of the perfusion tracers through the coronary vessels which are stenosed. So there is a heterogeneity in the availability of myocardial perfusion tracers in the myocardium supplied by normal coronary vessels and the myocardium supplied by stenosed vessel. So that is what is classically shown as a perfusion defect. So any or presence of any stress induced perfusion abnormality is a clear cut sign of presence of hemodynamically stenosis. And this particular statement holds true because the uptake of perfusion tracer is linear to blood flow over physiological flow range. But this may not be true, or this may not be true in presence of very high. But this very high flow rate, what we mean is an increase in the blood flow, coronary blood flow by more than 4 to 5 times. But even at the highest level of exercise, what the blood flow is more than 2 to 3 times. So for that physiologic flow range, the uptake of perfusion tracer is linear to the blood flow. And this holds true whether it is thallium or technetium based radiopharmaceuticals like MPI or tetraphosphate. So all of us are aware of this ischemic cascade. The only point I like to highlight in this ischemic cascade is the hypoperfusion precedes all other echo detected or ECG detected abnormalities like diastolic dysfunction, systolic dysfunction, ECG changes, or patient's clinical symptoms like angina. So all these things are preceded by the hypoperfusion, which is going to be detected by the myocardial perfusion imaging. So that clearly states the importance of performing a myocardial perfusion imaging as far as the detection of ischemic heart diseases are concerned. So let us now discuss the various radiopharmaceuticals that are being used in detail. One is 201 thallium, available as thallus chloride, and it has a half-life of 72 hours. And the uptake of thallus chloride is proportional or is facilitated by the presence of sodium potassium ATPase pump. Because it is a potassium analog, so potassium and thallium comes in the same group under the periodic table. So all the physical and chemical characters of potassium and thallium are the same. So because it is pushed into the myocardium, into the viable myocyte by the sodium potassium ATPase pump, the thallus chloride also is pushed into the myocardium using the sodium potassium ATPase pump. And the uptake of thallium is proportional to the blood flow, and it is an active transport. But we must keep it in our mind, the thallium is not taken up exclusively by the myocardium, it is also taken up by the skeletal muscle. So only the 4% of the injected thallium is taken up by the myocardium during peak stress. So what is the meaning of this statement? So 96% of thallium is available in the skeletal muscles in the intravascular compartment and for the excretory organs like kidney to excrete it out. But there is significant amount of thallium available in the intravascular compartment and also in the skeletal compartment for a phenomenon called redistribution to take place. So what is redistribution? It is something like an osmosis where there is a movement of the material from a high concentration to a low concentration over a period of time. The same thing happens in the thallium redistribution also. There is a continuous efflux and influx of thallium from skeletal muscles into the intravascular compartment, from intravascular compartment into the myocardium, and vice versa over a period of time. So the presence of perfusion defects precipitated by the presence of coronary stenosis can get equalized after some time. After some time here the redistribution happens over a period of 4 hours. So if you do a re-imaging of the myocardium after 4 hours, what you will get is the perfusion status of the myocardium at rest or redistribution images. So this redistribution is facilitated by the continuous efflux and influx of thallium into the myocardium and out into the intravascular compartment from the myocardium. The same phenomena will be taking place from the skeletal muscles into the intravascular compartment, so that there is a continuous replenishment of thallium to the myocardium over a period of time. So you can actually image the patient at rest without re-injecting the patient. So that's the advantage of thallium over system EB as far as the imaging part of the myocardial perfusion imaging is concerned. But I have already highlighted the fact that we always prefer to do most of the myocardial perfusion imaging studies with technetium based radiopharmaceuticals, and these are the two radiopharmaceuticals available and commonly used or labeled with technetium. System EB is MIBI. This is a lignocaine related compound and it has a free distribution into the myocardium. This is an isonitrile compound and the uptake is proportional to the blood flow, but there is no redistribution. It is, you have seen in the previous thallium, it is an active transport. Here it is a passive diffusion, viable myocyte or active myocyte, and the uptake is proportional to the blood flow. Why we insist on technetium labeled radiopharmaceutical? Most important is its cost effectiveness. If you have 3 patients scheduled for a thallium study, you need 6 millicurie of thallium. Each millicurie costs around 3,000 rupees. So the more the number of patients, you have to order more thallium. But on the other hand, if you have one system EB vial which costs around 10,000 rupees or 7,000 rupees, you can actually do even 5 cases to 6 cases of myocardial perfusion on the same day. So the cost effectiveness is maximum with technetium labeled radiopharmaceuticals. Not only that, it gives excellent quality images because we can inject larger radioactivity into the patient as far as technetium is concerned, because the technetium lives only for 6 hours. On the other hand, you have seen in thallium it is having a half-life of 72 hours. So it gives more radiation to the patient. On the other hand, technetium gives less radiation, better quality images, and also you can do a specific procedure called gated images. By doing a gated images, we can assess the wall motion and wall thickening of the left ventricular myocardium during the myocardial perfusion imaging procedure. So you get both information, that is the perfusion status of the myocardium, also presence or absence of wall motion abnormalities using the gated study. So how a patient is taken up for a myocardial perfusion imaging, or how myocardial perfusion imaging is performed. It is conventionally done as a stress rest protocol, and this stress rest protocol can be done as a 1-day protocol or a separate day protocol or a 2-day protocol. Conventionally it is done as 1-day protocol, especially in a high volume center like ours, because you can do the stress imaging in the morning and rest imaging in the evening. Or if you have a patient with a low probability to have coronary artery disease, then you can do something called separate day protocol, where the patient is injected with a higher radioactivity during stress, and if the stress is absolutely normal, he will not come the next day for a rest imaging, he will have only a stress imaging. But conventionally for children, because they have a high probability to have coronary artery disease, especially in the background of congenital heart disease, this is the procedure that is conventionally performed in our center, that is 1-day stress rest protocol. These children are being injected with technetium of 0.2 millicurie per kilogram body weight, and if you use thallium, you will be injecting 0.05 millicurie per kilogram body weight. it roughly turns out to be 2 to 3 millicurie for stress. When you do a stress imaging, the rest imaging done after 3 to 4 hours always is done with a higher radioactivity, conventionally in the multiples of 2 to 3. Here I have given, when you use 2 millicurie, you will be injecting 4 for the rest, and if you inject 3 millicurie of technetium in the morning for stress procedure, you will be re-injecting the patient with 6 millicurie in the evening for the rest procedure. But if you are doing a separate day procedure, then you can inject a higher radioactivity. What is the advantage of higher radioactivity? Your image quality will be still better, and also your gated procedure or gating images will be still better. But having told that, you can get an excellent quality image even with this one day stress rest protocol, where you are injecting only 2 millicurie in the morning, 4 millicurie in the afternoon. If you are looking only for the presence or absence of myocardial viability to a stress procedure, we don't need to provoke or to show the presence or absence of provocable ischemia, then you need to do only a rest procedure where you keep the coronary arteries in the most dilated way, that is by giving a sublingual sorbitrate or an intravenous nitrate infusion, then followed by the injection of technetium labeled sesame B or thallium injection. So this rest only procedure is preferred for patients where our primary concern is the presence or absence of myocardial viability. The same MPI protocols are done with thallium, then we call these images as stress redistribution images. I have told that we inject less amount of thallium because of the fear of more radiation exposure. So the conventional dosage is only 0.5 to 1 millicurie at stress, and there is no re-injection for rest. So the redistribution images are conventionally acquired after 4 hours. So that will replace the rest imaging done with technetium sesame B. If you are looking only for the presence of myocardial viability, then you do a rest redistribution image, that you inject 0.5 to 1 millicurie at rest, 4 hours or 1 hour later you can do a redistribution images, and that will show the presence or absence of myocardial viability. So we do a stress rest procedure if we want to show the presence or absence of provocable ischemia. If we want to show only the presence of myocardial viability, we do the only rest procedure. If it is the case of known myocardial infarct plus minus reversible ischemia, then we do both stress and rest procedure. So these stress procedures can be either stress, conventional exercise in the form of treadmill or ergometer exercise, or you can also stress the patients with pharmacological agents. It's of paramount importance to understand the physiology and also the dosages of the pharmacological stress, because especially in children, we most of the time we end up doing a pharmacological stress. So we will understand both. So if we want to give a conventional exercise, that can be done with a symptom limited treadmill. If we don't want to stress the patient using a treadmill or ergometer, or if it is not possible, especially in 3 years, we can do a pharmacological stress. The pharmacological stress can be a vasodilator drug like adenosine, or a dobutamine which increases the force of contraction and the rate of contraction. So either we can use dobutamine or adenosine. When we use dobutamine, we go up to a maximum of 50 microgram per kilogram body weight. We normally start with 10 microgram per kilogram body weight, and every third minute we increase the dobutamine doses to 20, 15, 20, 25 like that, up to a maximum of 50 microgram. In adults, it is the maximum dosage is around 40 microgram, but because the target heart rate in children is so high, we always augment the rate of contraction by increasing the dosage up to 50 microgram. Also, we use injection atropine. The dosage of atropine is from 0.01 to 0.25 milligram per kilogram body weight. In our center, we normally use 0.1 milligram per kilogram body weight, and the maximum atropine dosage that is given at the time is 1 milligram. So you start the dobutamine infusion using an infusion pump at 10 microgram per kilogram body weight. You go to 15, 20 up to a maximum of 50. At 50th microgram of dobutamine, you inject atropine if the target rate is still not achieved, and at the maximum or the peak pharmacological effect of the atropine and dobutamine, you inject the sestamide or thallium, then do the stress imaging. If you are doing an adenosine procedure, adenosine is a selective vasodilator of the coronary vessels, and the constant dose of 1.14 milligram or 140 microgram per kilogram body weight infused over a period of 6 minutes at a constant infusion rate. At 4th minute of this infusion, you give the injection of sestamide or thallium, then continue the pharmacological infusion of adenosine for 2 more minutes and stop the adenosine infusion. If the child can understand our commands, then we can even add isometric hand grip exercises also. Thereby we increase the heart rate. More importantly, we distribute the adenosine to the other muscles. Thereby the unwanted side effects of adenosine like the stimulation of beta 1 and alpha 1 receptors are avoided. Thereby the patient is very comfortable with adenosine. The antidote that is used for adenosine is aminophylline, especially in children. After the infusion of adenosine, we give the aminophylline also as an antidote so that there is no prolonged action of adenosine. For dobutamine, if we have any problem during the infusion, the conventionally used antidote is IV esmolol. So let us now discuss the interpretation of myocardial perfusion scans. So what we are actually shown is what is being shown here is the myocardial slices in 3 different axes: short axis, vertical long axis, and horizontal long axis. The short axis images are from apex to base. It gives a bird's eye view of the left ventricular cavity. The images are shown in 2 rows. The first row is stress images and the second row is rest images. The vertical long axis shows the perfusion pattern of the myocardium in the anterior, inferior and apex. The horizontal long axis images are depicting the myocardial perfusion status of the septum, lateral wall during stress and during rest. There is a color grayscale always will be associating these images, so that shows the distribution of the myocardium, distribution of the perfusion of the myocardium, or distribution of the myocardial perfusion tracers. So it starts from black and it ends with white. So all the blackened areas are showing less myocardial perfusion, and all the pink and white are showing normal perfusion to the myocardium. So naturally you can see the left ventricular cavity shows no tracer presence. So that is the myocardial cavity. It's an absolutely normal myocardium. So you don't show any myocardial perfusion defects during stress. So the basis of any interpretation of a myocardial perfusion imaging is, first you look for the presence or absence of myocardial perfusion defects during stress. If there is nothing, then we are going to call this as a normal study. If there is a myocardial perfusion defect during stress, then we look forward for its reversibility or improvement during rest. Then it is the presence of reversible ischemia. If there is a persistent perfusion defect both during stress and rest, then it can represent the presence of an infarct, or sometimes it can also be an attenuation artifact. But in children we don't come across too many attenuation artifacts, and it is almost always because of the presence of a pre-infarct. So any persistent perfusion defect in a myocardium during stress and rest is synonymous with an old infarct, and reversible perfusion defect is classic presence of reversible or provocable ischemia. So the same visual interpretation also can be quantitated using polar map. So this polar map is a computer generated map, but this map is generated using the patient's own data. It is basically the stacked up images of the short axis from apex to base shown as a polar map, and this particular stress rest map is compared to a normal database. This normal database is created and already loaded into the computer, but most of these data are Western data, and it has to be kept in our mind. These data are adult data. We don't have a pediatric data, but this is an age matched, sex matched patients with low probability to have coronary artery disease, less than 5%. They undergo an angiogram, they undergo a myocardial perfusion scan, and their images are used as a reference, and to that we can compare our patient's own data, and it shows the presence or absence of reversibility in this myocardium. Once again, I like to highlight that polar maps are only a surrogate marker for presence or absence of reversible ischemia, and the interpretation, especially in children, is almost always visual using the conventional interpretation of stress rest images in short vertical and horizontal long axis images are being used for that purpose. So the same study done using a gated study. These gated studies are easy to be understood. You take the cardiac cycle. This cardiac cycle is divided into many frames. Conventionally, it is divided into 8 frames. So 4 frames during diastole and 4 systole, and you register the perfusion status of the myocardium during the various phases of the cardiac cycle. Thereby, you get the gated study. These gated studies are extremely useful in understanding the ejection fraction and the presence or absence of regional wall motion abnormalities. So you can actually calculate the end diastolic volume, end systolic volume. Also, you can actually calculate many other indices like diastolic indices like peak to filling, time to peak filling rate, time to peak ejection rate. All those things can be calculated using these gated images. Also, these gated images are extremely useful in the understanding of the presence or absence of regional wall motion abnormalities. So here is a patient with an anterior wall MI. You can see that there is a significant hypokinesia of the anterior wall. Also, there is no wall thickening at the infarcted area. These are the short axis images at the apical, mid cavity and the basal slices. This is the horizontal long axis. Here you can easily understand that this is the left ventricular cavity, this is the right ventricular cavity, this is the right ventricular myocardium, this is the septum, lateral, anterior, inferior and apical walls of LV myocardium. I personally feel this is better than an echocardiography because you can register, you can see n number of times, and the wall thickening is beautifully shown by the thickening of the myocardium, and you can use this color gray scales also. Also, you can accurately calculate the rest ejection fraction, also the other systolic and diastolic indices. Not only that, these indices can be created from a myocardial perfusion imaging. I told in the initial discussion that the biggest strength of nuclear medicine imaging is the quantification. So here we can accurately quantify the number of myocardial segments having viability using this semi-quantitative visual analysis. So you can actually take the apical, mid cavity, basal short axis slices and the mid cavity vertical long axis slices, and you can actually calculate the number of segments with viability and without viability. Also, you can calculate these presence or absence of perfusion defects using this summed stress score, summed rest score. So these are independent prognostic markers in the patients with provocable ischemia. Also, these are independent markers of prognosis in the evaluation of myocardial viability or the revascularization strategies are concerned. So these images I am just trying to show to make you understand how the semi-quantitative number of segments are calculated when we do a rest only study. You can see that there are only one row of images. These are the rest images in two different colors. So these colors are being used. This is for the interpretation for the presence or absence of perfusion defect, and this is for quantification of the uptake of systemically or thallium. So these are exactly 0 to 100%. So anything more than green and fluorescent green clearly indicates that the myocardium has more than 50% of MIBI or thallium uptake. Thereby, we can confidently say that these myocardial segments. So this is a patient with anterior wall MI with an ejection fraction of only 30%, and these myocardial segments are significantly viable, rather they are hibernating. So how to understand that? Here are two patients with the same history of extensive anterior wall MI with an ejection fraction of 30-30. This is the thrombolized patient, and this patient didn't have thrombolysis because of late presentation. Both patients have proximal LAD stenosis by angiogram, but only myocardial perfusion scan can prognosticate this patient who will improve with revascularization and who will not. Here is a patient with significant viable hibernating myocardium in the infarct zone, and here is a patient with no viable myocardium, only scar tissue. The scar tissue is shown by the presence of black and blue colors here. On the other hand, here the entire infarct zone shows more than 50 to 60% systemically or thallium uptake, thereby clearly indicating the presence of viability. So coming to the challenges in pediatric MPI, why the myocardial perfusion imaging in pediatric is not being widely performed? That is because of a lot of problems from our side also with children. We really don't know what stress protocol we have to follow, whether it is exercise or adenosine. Experience and with the others' experience in the literature, we can confidently now say that any children of more than 4 years who can understand and who shows interest to walk on a treadmill can be taken up for an exercise. They can be either stressed on a treadmill or on an ergometer, especially in Western countries, Europe countries, they prefer ergometers. But in our setup, we use the treadmills. But these adult treadmills may not be a comfortable equipment on which the children walk, but still we don't have an option. But if we have a treadmill which is tailored down for a child, probably that is the most ideal way. But still, in some specific instances, the pharmacological stress is preferred, like children of less than 3 years. Also, in specific disease conditions like Kawasaki, where to do serial myocardial perfusion imaging. Here, during the serial myocardial perfusion imaging, the endpoints of exercise can change because target heart rate changes according to the age. But that will not be changing as far as pharmacological stress is concerned, especially with adenosine, because it is always a 6-minute constant infusion protocol. But as a general practice in our center, we always prefer exercise for children more than 5 years and who are interested to walk on the treadmill. And for children less than 3 years, 4 years, we use adenosine as a conventional pharmacological exercise. But the problem doesn't stop there. Imaging is a big challenge because we need to have a motionless acquisition, and for that conventionally we give oral triclophos or we use IV midazolam, and the imaging is normally done for 5 to 8 minutes only. But during that 8 minutes we need an absolute motionless acquisition, then only the images will be free of artifacts. Also, liver clearance of systemically or thallium is a big problem, especially in children. So we need to wait at least for 1 hour after the injection of technetium systemically during. There is always a worry about radiation exposure from the clinician's point of view, but I can only assure you that what the patient gets as the radiation exposure is much less, especially with technetium labeled radiopharmaceuticals. You will be really surprised to note that the radiation exposure what this patient gets from a myocardial perfusion imaging is lesser than a radiation exposure which would have been got with 2 or 3 chest X-rays that may have been done for this patient. So we really don't need to worry about the radiation exposure for myocardial perfusion imaging, especially in the era of technetium labeled radiopharmaceuticals availability. This just shows you how difficult is the interpretation can be in children. This is a 2-year-old child with a congenital agenesis of the thyroid gland who is undergoing myocardial perfusion imaging for the assessment of Kawasaki disease. This is an adult patient. You can see an excellent uptake in the myocardium, not so good uptake in the myocardium in child, and very high liver activity or liver uptake, which will over a period of time will clear through the hepatobiliary route. So only we like to wait for a minimum of 1 to 2 hours. Naturally, the logical question comes. So will there be a change in the myocardial perfusion pattern during this 1 to 2 hours? It will never be, because it's the still picture of the myocardial perfusion status at the time of injection, because there is no redistribution happens with technetium labeled system. But the myocardial perfusion status can significantly change. It changes after 10 minutes if you are doing a thallium study. So literally thallium imaging is not preferred in child, rather technetium labeled system is the imaging radiopharmaceutical of choice as far as children myocardial perfusion imaging is concerned. Now coming to various indications as far as congenital heart disease is concerned. I think we have significant experience with Kawasaki disease, Al-Kappa, and hypertrophic cardiomyopathies. The others we mean only myself, most of our nuclear medicine colleagues don't have too much of experience, not only in India, even in abroad countries. But let us go through the various findings that can be expected in these disease conditions. Myocardial perfusion imaging is the imaging modality of choice as far as the follow-up of Kawasaki diseases are concerned, because you can actually identify the appearance of ischemia. If the myocardial ischemia is already established in a patient by any other imaging modality, you can see its aggravation over a period of time. So this is the most non-invasive and easy investigation as far as the assessment of asymptomatic or insignificant or significant ischemic heart diseases are concerned in Kawasaki's disease. Also, it is a very useful investigation in the assessment of coronary revascularization in these patients. Whether you do an exercise MPI or a pharmacological MPI, you get an excellent sensitivity in the range of 70 to 90% in the detection of coronary stenosis and in the detection of physiological significance of this coronary stenosis. Just trying to take you through 1 or 2 images which we have done. It's all our own images. This is a 5-year-old boy who has a coronary ectasia involving the left main, who is undergoing serial studies. It's an absolutely normal study. You can make out that there is no left ventricular cavity dilatation. There are no reversible perfusion defects either in the LAD territory or the RCA or the circumflex territory during the stress. Because there are no perfusion defects both during stress and rest, we are confidently telling that this patient didn't have any previous infarct and there is no provocable ischemia. He had the exercise on a treadmill and he achieved 100% target heart rate also. This is a 12-year-old girl who had a LAD ischemia. So this is a patient who shows significant perfusion defects. So it is obvious that the distribution of the myocardial tracer, especially in anterior and apex, is less during stress, and it partially reverses during rest. So this is although she is asymptomatic, she had a previous infarct in the anterior wall and still shows residual or provocable ischemia in the LAD territory. So we are confident about absence of reversible ischemia in RC and LCX territory, and we can quantitate the extent of reversible ischemia in this patient using polar map. Even otherwise, the semi-quantitation which can be done using the stress and rest images. A summed rest difference score of more than 3 is highly significant as far as the significance of this reversible ischemia in LAD segments are concerned. So that can be calculated. You calculate the number of segments showing defects during stress, that is summed stress score, and you calculate the number of segments with perfusion defects during rest, that is summed rest score. Summed stress score minus summed rest score is summed difference score, and that shows the extent and severity of the reversible ischemia. This is one more unfortunate patient who had a left ventricular aneurysm involving the lateral wall. Also, there is presence of reversible ischemia in the posterolateral and inferior segments. Patient has Kawasaki disease involving the circumflex and RCA. So here the effect of the infarct is clearly shown, a perfusion defect, persistent perfusion defect in the inferolateral segment, and you can see there is a perfusion defect involving the inferior wall which is becoming normal during rest. So this is reversible ischemia in the RCA territory and infarct in the LCX territory. This patient had a angiogram also showing the left ventricular aneurysm involving the lateral wall also. Rather, this patient came for the myocardial perfusion scan after the angiogram. So in tetralogy of Fallot repair, after the repair, we can look for the presence or absence of residual or inducible ischemia. Also, we can assess the overall ejection fraction and overall left ventricular function, presence or absence of wall motion abnormalities. This is again another patient of our own. You can see that there is a dilated right ventricular cavity. Till now, you would not have seen the presence of a right ventricular cavity at all. That is because when there is normal perfusion, the majority of the perfusion tracers are taken up by the left ventricular muscle mass, and any appearance or any visualization of the right ventricular cavity with good uptake in the, what I meant was the uptake in the right ventricular myocardium, if it is significant, that clearly shows the presence of right ventricular dysfunction, right ventricular volume and pressure overload. So that is clearly shown in this patient. You can see right ventricular cavity dilatation, significant uptake in the right ventricular myocardium. There is a hypertrophy of the right ventricular myocardium also, but you see the left ventricular cavity. This is not showing any perfusion abnormalities. Again, please understand that this is a rest study, no stress images. This is mainly to assess the presence or absence of the right ventricular hypertrophy and right ventricular damage, is there presence or not. So here we show that there is a significant uptake in the right ventricular cavity myocardium and no perfusion defects in the left ventricular myocardium. I personally feel both in Al-Kappa and Kawasaki disease, myocardial perfusion scan is a very important investigation which gives enormous information. Especially in advanced cases of Al-Kappa, if we are looking for the presence of myocardial viability, the viability detection is best done with a simple myocardial perfusion scan at rest. This is an important information because this is going to decide about the therapy of a high risk revascularization in these patients. And as we have seen in previous images, what we are looking is presence or absence of perfusion defect. Also, we look forward for the presence of technetium or thallium uptake of 50% when compared to the best perfused area. So any segment showing 50% or more of technetium or thallium, we can confidently say that these areas are viable, and with revascularization they are going to do better. Also in patients of asymptomatic Alcapa or patients who already had surgery, if we are looking for any fresh ischemia, the myocardial perfusion scan is the imaging modality of choice. And what we are looking forward is the presence of defects in the apex and inferior segments of LV myocardium. Also, this is an important information that can be got from myocardial perfusion imaging is most of the time there is a significant confusion between the Alcapa and also the congestive cardiomyopathy in these patients, and this is easily distinguished by a myocardial perfusion scan. Again, a simple rest myocardial perfusion scan, because what you are actually looking in a congestive cardiomyopathy is apparent perfusion defects, meaning there is no significant perfusion defects in a grossly dilated LV with severe hypokinesia in gated images. On the other hand, in advanced forms of Alcapa, you are going to show significantly important perfusion defects in the lateral and anterior segments, that is the left main disease or the left coronary territories. You are going to show significant perfusion defects. So this is an important and easy differentiating congestive cardiomyopathy from advanced Alcapas. But unfortunately, even though ACC and AHA guidelines are there for the utility of MPI, it has to be done every 3 to 5 years post Alcapa repair. Nobody does. It's not only with us, even the other studies have shown that it is being sparingly used. But take it granted, it has a real scientific value in differentiating these two, also in the prognostication and to looking forward towards a fresh asymptomatic ischemia in these post Alcapa repair. This is a very useful investigation. So this is another patient, which is again our own patient, showing a previous infarct. You can see that there is a persistent perfusion defect in the LAD territory, but if you carefully look, there is a partial improvement. So this partial improvement shows peri-infarct reversible ischemia or ischemia around the old infarct in the LAD territory. So representative slices I have shown: short axis images, stress rest; vertical long axis, stress rest; horizontal long axis, stress rest. There is no perfusion defects either in the inferior or lateral, so RC and LCX are spared, but significant partially reversing perfusion defects, especially involving the anterior and the apical segments, that is the LAD territory. This is a suspected case of advanced Alcapa, but it is basically a congestive cardiomyopathy showing apparent perfusion defects with a grossly dilated LV, and the gated images show significant global LV hypokinesia. It is also useful in the arterial switch operations post ASO surgeries, because what we are actually looking forward is the left coronary stenosis or left coronary territory. We are looking for the reversible perfusion defects both in the apex and lateral wall, that is LAD and circumflex territories. It has to be kept in our mind, this is not only because of the distal LCA stenosis or left coronary stenosis, it also because of the abnormal vasomotor tone, which is always expected in these type of patients. So you can, if you see reversible perfusion defects, that indicates the presence of reversible ischemia. But even at rest you can see perfusion defects, that is the myocardium which has already got scarred. So coming to the cardiomyopathies, mainly the hypertrophic cardiomyopathies, because in hypertrophic cardiomyopathies and patients with significant left ventricular hypertrophy, you are going to see compression of coronary arteries and especially their septal branches, and most of the sudden death in these hypertrophic cardiomyopathy children is not because of ventricular arrhythmias but because of ischemia. And there is no other investigation as good as MPI as far as the identification of these reversible ischemias, especially in asymptomatic patients. Also, I feel this is a very useful investigation in this specific condition where the patient is unresponsive to medical management and you are planning for a septal myomectomy. So when you are doing a septal myomectomy, you can easily show the septal hypertrophy by a simple rest myocardial perfusion scan. Also, you can show the presence or absence of reversible ischemia in the left coronaries. Also, whenever there is a surgery which may compromise the septal perforators, myocardial perfusion scan is the most useful investigation because you can actually show the real segments. For example, if there is an isolated involvement of the septal perforators getting compressed or getting closed after this surgery, you are going to show isolated reversible perfusion defects in the septum. Also, it is very useful in the assessment of early diastole, and we are actually looking for reversible perfusion defects in the advanced cases of LAD ischemia in the anterior septal and apical regions. Also, in Duchenne muscular dystrophy, we can look for the myocardial degeneration. Here, most of the time, it involves the infero-basal and lateral walls, and as the transmural fibrosis and fatty infiltration advances, the myocardial perfusion defects also advance into the infero-apical, mid-inferior, also the anterior LV segments, but it always starts with infero-basal and lateral walls. Although we don't have any experience in cardiac transplant, for the early rejection we have a very specific imaging modality where you use annexin 5. Annexin 5 is specifically used for apoptosis imaging, and this is a Technetium labeled annexin 5 which is commercially also available, but we don't have experience because we have not done any scans here. But basically what you are looking is any apoptotic segment or any early rejection is going to show increased uptake of annexin 5, and that is something called hotspot. Till now we were seeing a reduced perfusion defects, but here you will look forward for an increased annexin uptake in the form of a hotspot imaging. Coming to the last indication, that is the RV estimation or RV evaluation by myocardial perfusion imaging. As we have discussed, normally right ventricle is not visualized, that is right ventricular myocardium. But if there is pressure overload and increased pressure and increased volume overload, what you get is something called inverted design. That is, the septum becomes hypertrophic, intraventricular septum, and there is an increased uptake of system B or thallium in the right ventricular cavity. So it looks like a D getting inverted. So the uptake is there in the septum and the inverted D, that is the right ventricular myocardium. Also, you can do a first pass radionuclide studies whereby you can exactly calculate the right ventricular and left ventricular ejection fraction, and we can actually assess the global RV function, whether it is depressed or it is normal. So RV pressure and RV overload can be estimated by myocardial perfusion scanning. So to conclude, whenever we are looking for an ischemic heart disease, and if you want to assess the physiological significance of any known coronary lesion, or if you want to collateralize to assess the significance of the collateralized vessels, the myocardial perfusion imaging done with stress is the imaging modality of choice. It is the investigation of choice specifically in specific disease conditions like Kawasaki and also Kappa because of its excellent reproducibility. Also in any disease condition where you are going to take up the patient for a high risk revascularization procedure and you want to exactly quantify the presence of myocardial viability, a simple tomographic myocardial perfusion study or a gold standard PET study are indicated. That is because of its ability to differentiate a viable myocardial tissue from scar tissue. So I think I have taken enough time. If they ask any questions. Any specific questions can be asked. Yeah. And I think any very high revascularization procedure where you are looking for a viable and they don't go for a yes, it's just injecting 1 hour later you take a page faster. We have an excellent health cardiac patient don't take up the patient for a clearly indicate who are the patients, who are the patients, or myocardial contributing from a cardiac we always prognosticate who are the patients who is going to